Rajitab kolenjin atochin mising en kebeberta nebo oeng nebo tetutiet nito bo tililindo neitun kila ko Jumatatu en ketesiet nebo Kass TV. Miten ireu nekotoche sang Karo, ane ko Victor Korir, kemiten en studio ak tondet ne inendet ko konyoindet en sipitalit nebo Moi Teaching and Referral Hospital. Kimiten ak inendet en ireu keng'ololi akobo koimutiet nebo miondo nebo seriat noto nebo bwonek anan lung cancer. Mioni ko miondo ne ityin biik chenekit sire 1,000 en kila kenyit ako ibeti biik sobonwek cheite 800 en kila kenyit kora kobun mionitok. Ako kikomong'e kibagengeisiek cheterter asikomuch koborien miondo nito bo lung cancer ako neindoi en choto ko sipitalit nebo Mtrh en Eldoret netindoi icheket clinic nebo oncology noto ko netinye ak ng'alek chebo cancer noto bo bwonek. Ak amache ketiketaitondenyon en studio Bwana Lawrence Murunga. Nimekuwa nikieleza watazamaji about the fact that this cancer, lung cancer, is a problem which affects upwards of 1,000 people, new patients probably every year, and it's one of the most devastating cancers we have. Some of the information I have here is that it is the 5th most common cancer, but it has the highest mortality.
Very true.
So average of 40 deaths per year as per the cases being managed at Mtrh. So kindly, before we even delve into this issue, maybe you can just, introduce yourself. I've let the viewers know that you're Lawrence Murunga, but who is Lawrence Murunga?
Indeed.
Yes.
Thank you very much, Victor. It's a privilege and a pleasure to be here. As you rightfully mentioned, my name is Lawrence Atundo Murunga.
Yeah.
I am a clinician, basically, but I'm also privileged to be leading a program under the supervision of many other people, including our lead program investigator, that is a principal investigator, Professor Mtrh. So I work as a program manager with a program that is based at Chandaria Cancer building, or rather Chandaria Chronic and Disease Center in Moi Teaching and Referral Hospital. This project is among the many projects that are within the Moi Teaching and Referral Hospital Oncology and Hematology. We are affiliated with Ampath, and the project, by virtue of it having a wider picture of many partners within sub-Saharan Africa and basically the larger section of the sub-Saharan region, we are referred to as the name Multinational Lung Cancer Control Program.
All right.
So Ampath Multinational Lung Cancer Control Program is a program that is primarily funded but USAID-based philanthropists, that is a foundation known as Bristol Myers Squibb Foundation.
Yeah.
We have clear mandate within this program, and one of the main things that we do is to ensure that there is access to treatment and care for lung cancer patients. And we have various strategies in place that enable us to scale up the cascade from a household level of an individual who is presenting with signs and symptoms that are congruent to lung cancer to the diagnosis, management, and treatment for that particular patient, which maybe we may have the privilege to discuss more.
We'll discuss about the program later on, but for a start, we could just start by understanding, we dissect this issue of lung cancer.
Indeed.
Because there might be a number of complications that might be mistaken for lung cancer.
Indeed.
So we need to first understand what is lung cancer. From your perspective as a clinician who is interacting with this problem on a daily basis, what could you describe, or how could you describe lung cancer? What is it?
Indeed. Lung cancer is primarily a cancer that begins in the lungs. Many times you have cancers that are driven, or they metastasize to the lungs. But in this case, we are looking at the lungs that begins, the cancer that begins in the lungs, that originates from the lungs. And it may be in any part of the lungs. It may be the apical area, it may be the basal area, it may be the lobes, it may be centrally, but basically it begins from the lungs. And cancer per se is the proliferation of cells, where the cells grow out of control and they become what the scientists would call apoptosis. They don't die. They're not, they don't go through the natural death process that the usual cells will go through. So then they grow, meaning they become, they manifest in a mass form. So primarily, when you look at a cancer in the lungs, you manifest with a nodule. It begins with a nodule, maybe a smaller one, then grows up to become a mass. So then the mass could manifest as a lung cancer after it has been diagnosed. And we do not say someone has lung cancer until we do biopsy. And this biopsy then entails picking a piece of the sample, not much, but a sample from the mass in the lungs, and then taking it to the proper procedure in the laboratory to eventually end up diagnosing with the cancer. So once that is done and it's been realized under the microscope in the pathology lab that this is, then the cells are a reflection of the cancer, then we say it is primary, especially after we have done further characterization with what you call IHC to ensure that this is not a metastatic cancer to the lungs, but rather the one that originates from the lungs. Then we say you have lung cancer. But otherwise, not every mass in the lungs is lung cancer. So when you have a mass in the lungs, the best thing is to take the biopsy, because where we come from, we say tissue is the issue. So you have to have the tissue to take it to the laboratory to look at it and say this is actually cancer, and then it originates from the lungs. Then so you say you have lung cancer.
Then now from there you can proceed to
proper care.
To proper care of a patient.
Yes, yes.
You said it originates from the lungs. What are the common symptoms? That probably most of the time people who have lung cancer present with when they come to the hospital? What are some of the main ones? Because the people who are watching, though we are not doing a diagnosis over the television, we just want people to be aware so that if they come across these symptoms, they give it a bit more attention and seek relevant opinions. So what are some of these symptoms?
I'll say in a nutshell, lung cancer signs and symptoms, if I may call them, are basically those that are related to upper and lower respiratory tract infection. These symptoms camouflage or reflect closely to what the TB symptoms manifest. And that's why we usually associate, we have a close working relationship with the TB clinic, so that if then the person presenting with these symptoms, they rule out not to have TB, then we ask, what next could it be? The most common symptoms, a cough that doesn't really go away with the empirical treatment. Other symptoms include chest pain, difficulty in breathing. And you see some of these symptoms are because of the growth of the mass, because it also then presses on important organs in the body and makes you to manifest otherwise. We also have those that are related to pressure symptoms. So we have the chest pain, difficulty in breathing. You could also be able to manifest with loss of weight, because remember, cancer generally takes a lot from you. You may miss, rather not have appetite at all, and you may find yourself in a situation whereby you're not able to. There's also, easy fatigability, where you are not able to do the usual exercises per se, because remember the lungs are compromised, and therefore this particular patient, if they were running, now they can't run. If they are climbing the stairs, now they realize they're getting very tired. They cannot be able to breathe properly. More so, the tiredness is because of the lack of proper ventilation oxygen in the body. And then many times then you find these people having a very low SpO2, that is the oxygen concentration in the blood. But primarily we've seen most of the patients who manifest with cough, chest pains, difficulty in breathing, as I said, and also, long other signs of symptoms like, finger clubbing. But those ones are much later. But the first three are most common.
Okay.
Yes.
Okay. And knowing that these are the symptoms, at what point should someone get concerned?
Get concerned.
Yes.
Very interesting question, Victor. What we usually say is the best breakthrough for lung cancer diagnosis is to find it early.
Okay.
One of the biggest challenges we're facing as an institution and even as a project is that the index of suspicion is fairly low, both for the person suffering and for the person reviewing, which is a healthcare provider. Most of the healthcare providers think about many things. So is the person who is sick.
Yeah.
So what you're doing is to increase this index of suspicion to an extent that every other time you have a cough, you need to find out what is it exactly.
Okay.
Every time you have difficulty in breathing or chest pain, then find out what it is. So would usually in usual cases would say that if you have treated a cough, if you have tried to get treatment for anything, including TB, and you are still finding persistence in the very signs and symptoms that you're having, you should suspect yourself.
Okay.
And when you go to a healthcare provider, it is also very important for you to say, I have been treated for 1, 2, 3, and I'm not getting better.
Yeah.
And it's important for us to investigate further. And I say this because many of our patients that we've had, sometimes a good number of them have gone through various modes of treatment. They have done Mtrh a little bit.
Yeah.
They've done the over-the-counter medicine for cough.
Yeah.
They've bought cough syrups and tried to align the cough and to knock off the symptoms, but they are not going. They are persistent, because while we appreciate that lung cancer has that kind of mortality, you also get to know that it's not an acute illness. It doesn't, you don't get. It's not like a cold. You don't get it today, tomorrow you're coughing, and the next day you're gone. No, it sometimes builds up over time. So most of our patients have, in one way or another, seen a care provider, or even have what you call the alternative treatment, steamed under some eucalyptus trees, and sometimes have, gone to take some honey and ginger and the rest of the things. So to an extent, we have, by and by, a situation whereby someone has tried to remedy. So what we need to do is that every time you have remedied something and it's not going away, or it's not, the symptoms are still, becoming worse, suspect yourself. Go and have a further evaluation. And further evaluation in this case is that we need to have an imaging, because imaging, then we are able to recognize a mass. And if you're able to recognize a mass or a nodule, then it is easier to get an intervention. And as I mentioned earlier, the breakthrough in lung cancer diagnosis is to find it early. Once you find lung cancer early, then you're in the best position to manage it properly. And some of this proper management may not necessarily include the use of chemotherapy and what have you, though they may also be able to accompany. But the best management at stage 1 and stage 2 will be surgical intervention. And this can only be found if the mass is still localized and not spread
around the
through.
body.
Yes. So suspect. Every time you have a chest that is difficult, please suspect, because it doesn't hurt to go further and do something. Because there are many other conditions that may make you not feel better. We have COPD, we have other things that can make you not feel better with the treatment, empirical treatment. So if you go further and find out what you're suffering from, then it becomes better, because then you rule out whether you have lung cancer or you have COPD or any other, lower respiratory tract infections.
Okay.
Yes.
You're based in Mtrh, in the oncology clinic. You've said that this condition is best managed in stage 1, stage 2.
Indeed.
Yeah. Based on the statistics that you have gathered, what would you say, which stage is the most common when people are coming to seek for treatment?
Indeed.
Is it the early stages, or now someone has really developed this condition, the mass has really grown up to a point where now you rule out everything else? You're like, these are serious problems.
Indeed. Yeah, good question. The biggest challenge we face is, as I mentioned earlier, is to suspect early. We have a very small number of patients that we've ever diagnosed much earlier. In fact, I think there are only 1 or 2 patients we found in stage 2. The rest, the bulk of the patients are in stage 4. Wow. A few, very few are in stage 3. And that's one of the mandates that we're doing as a project. We want to see if you can do what we call stage migration, where we shift from diagnosing patients at stage 4 to diagnose them at stage 1 and or 2. Yeah. And those are the efforts we're trying to do. And that's why I'm very privileged to be here today to speak to everyone that if they have something in their chest that is not going away, they need to get it checked, investigated further. Yeah. So majority of our patients are stage 4, and that's what makes the mortality very, very, very high. Yeah. And we look at even the survival becomes very difficult. But the most interesting part to say, Victor, is that not all these patients are not within our reach. Some of these patients are actually within our clinics. Some of these patients are actually with us. Some of them are actually on anti-TB medication, for example. Okay. Some of them are being treated on some other lower respiratory tract infection. So the index of suspicion is the key thing for a breakthrough. Basing on what the TB programs are doing, using, for example, a chest X-ray as a basic evaluation tool, this can be able to grow because most of the patients who present such may be subjected to a chest X-ray, which is less harmful. When they are going for TB
diagnosis, yes.
So that's where we want to pick up most of our patients. But you realize that sometimes an early diagnosis of lung cancer may not be easily recognized as a chest X-ray because it's a small nodule, so it's growing. So most of the big masses can be picked with an X-ray because now you can see this X-ray is abnormal. There is something obliterating. Yeah. But then eventually, most of the diagnosis occurs much later in the stage. Yeah. And the most unfortunate thing is that lung cancer diagnosis is a little complicated. While we recognize the efforts that have been made in other cancers, diagnosis of lung cancer is not very easy because you have, remember what I said earlier, you must take a biopsy. Yeah. So for you to take a biopsy, you need an expert in that area. And we usually have what you call interventional radiologists who can see the mass using either ultrasound or a CT and be able to take a sample from that mass. Then it can be taken for evaluation. So those are some of the things that, quote unquote, may delay identification. But if you are found fairly earlier when there is a nodule instead of a mass, it is much easier to get to stage 1 or stage 2 diagnosis before you get to stage 4. But unfortunately, most of our patients, we find them in stage 4. And we are making efforts to create awareness, both at the community level and also at the healthcare facility level, so that then individuals are working in unison, both the patient and the care provider, to suspect that it could be lung cancer and then get early diagnosis.
Daktari, I've just realized that probably, I don't know, the cost of this process of investigating if someone could be suffering from, could be developing some sort of mass in their lungs so that you can rule out, you know, if it's lung cancer, how accessible is it? Because that might be something that someone might decide, like, okay, maybe I should get myself checked out, but maybe there's a barrier.
Yes, indeed.
Yeah, what is the cost of this particular portion of investigating? Yeah.
The cost related to lung cancer diagnosis and investigation is fairly on the high end. One is that we recognize that simple procedures that can recognize the lung mass are expensive. For example, it is not easy for you to walk into a facility and say, I want a chest CT to be done. It has to be reviewed and approved, because then we also recognize the fact that exposure to rays through the chest CT can also be a precursor to lung cancer. Okay, and you don't want to expose someone who doesn't need those rays. Exactly. So then it has to be something that then warrants the exposure. In areas where lung cancer screening or whatever, in developed countries, they what you call the low dose CT. It's fairly, the rays are fairly low, so they can be able to expose the person. But coming to our area of accessibility and eventually diagnosis, we recognize that most of our facilities, especially the periphery facilities, the most they can have is an X-ray. So these individuals, first of all, need to qualify to go in for a chest CT, and then thereafter, the chest CT has to be interpreted and be sent. The cost is expensive. A chest CT in our settings could be approximately 8,500 or thereabout, or 8,000 shillings for chest CT. An X-ray, of course, maybe is around 800 shillings, so it's fairly affordable. But the best way to recognize this is a chest CT. Now, if you scale it up, before that, after the chest CT is done, you must remember that for you to be diagnosed, you must have an intervention radiologist review. So you go through evaluation. That evaluation, there are a lot of laboratory workups that you need, because then the intervention radiologist will not approve of you to go and get a biopsy done while you are not stable enough to withstand the procedure. Then they will not walk in blindly. They have to use either CT guided or ultrasound guided. With this, for them to take a sample, they need what we call a biopsy gun and a needle, a coaxial needle. The biopsy gun and coaxial needle, they go hand in hand. If you look at the price of a coaxial needle, it's market price around 5,000 shillings. So is a gun, so around 5,000. So we're talking about 10,000 shillings to buy the instrument, not to pay for the procedure. Okay? And then you're looking at the cost of the laboratory exercises that are supposed to be done, because you have to do INR and the rest, clotting factors and the rest of the things. Now, eventually, you find that patients who can be able to access or afford these procedures find a lot of challenges along the way. And that's why, as a project, we say, if we are in a position to support a patient to access these particular procedures that they can be diagnosed, then we do that. So it is, in a nutshell, it is fairly an expensive procedure for you to get a diagnosis. Because remember, at that point of the evaluation and the procedure, you have not had a diagnosis yet. So after the sample has been taken, then this sample is taken to the pathologist. And then the pathologist interprets it and then reads out the results to you. Now, it's after the results have been read to you that you can now proceed to say someone has lung cancer. So at that point of diagnosis, usually it is fairly expensive. Out of pocket, you're talking between 50 to 100,000 shillings, depending on where you're going to have these procedures. And we are very optimistic that with the advent of SHA, we are hopeful that some of these procedures can be taken up.
Taken care of.
Yes, by SHA, so that we can have our patients accessing. Because you can be able to arrive at the facility and you say, I have this and this problem. And everything is there, but you cannot be able to access these things because you can't afford them.
You can't pay for them.
Yeah, you can't pay for them. So this is a very important component of the care cascade that we wish that we will embrace together with SHA, considering that there's a component of evaluation or screening per se that is being covered by SHA. Then we should be able to have all our lung cancer patients evaluated, screened, and be able to access the care.
Okay.
Yes.
Another thing about lung cancer is, well, I think if you approach anyone on the street and ask them, what do you think is the #1 cause of lung cancer? The first thing will be smoking. But there are other people who have reported that they got lung cancer or their relatives got lung cancer and they weren't smokers. So what are the risk factors that predispose people to lung cancer?
Indeed. You've mentioned it correctly. Smoking is one of the main risk factors. And we recognize that, indeed, even as a project. Smoking alone as a single source adds up to a very good percentage. But it's also relative. We say that lung cancer is for everyone. You are just a step away from being diagnosed with lung cancer. You cannot say you are not a smoker and therefore you can never get lung cancer because a majority of our patients never smoked. Majority of them never smoked. We are looking at many risk factors that are cross-cutting. Some of them are known, some of them not known. So cigarette smoking, yes, we reckon that is actually a risk factor. But I'll say this. While we recognize that individuals in this country smoke, they don't smoke as much. Okay, there are countries where people really smoke. And that's why it becomes very difficult even as a clinician to calculate a 20 pack year for anyone. because many of the people who smoke may actually fall below that particular categorization. Because in the world of screening, they say an individual need to have a 20-pack year. 20-pack year means you're really smoking like almost a whole packet per day.
Per day.
You don't have that kind of number of patients. But we say this, anything that harms the lungs is a precursor to causing lung cancer. Okay. And in this case, we've seen very good number of our patients who never smoked, as you mentioned. Especially the female population. Most of them were cooking for their children and their husbands in the kitchen. And you know how our kitchen setups are. Yeah. You know, firewood, and there's no chimney, and there's a very small window, maybe because of security purpose. And therefore there is a lot of smoke accumulating in the house. And when you go in there to cook as a lady, as a woman, you inhale that smoke. So environmental pollution or indoor pollution is one of the causes that we highly suspect could be a precursor to lung cancer, especially for female population. However, there are other known causes, including asbestos, and we thank the government because it's working very hard to make sure that it also gets rid of asbestos within our buildings and the rest. And there are other causes, some of it as we had as radon. Radon is odorless and colorless gas that when you inhale, then it gets to injure the lungs and subjects you to probable, cause lung cancer. So we can't escape this. Causes of lung cancer are varied. What is most key is that it can be in the environment. Okay. And if you smoke, get help to stop or to quit smoking. If you are working in an industry, please use universal precautions. Wear a mask. Make sure that you have your area of you're breathing clean air. I've seen people who do painting, and after they've done their painting, they say, just give me a glass of milk and I'll be okay. But you realize that this glass of milk, the area where it's going,
go into the lungs.
It doesn't go to the lungs.
It goes to the stomach.
Yes, so it may soothe the throat, but the truth of the matter is that inhalation of the fumes and what have you is bad. So we advocate for people to embrace universal precaution. Use a mask, align yourself with the universal precautions. Make sure when you're spraying your farms, and I want to talk to people within Western Gishu, we do a lot of farming there. You have patients who have had lung cancer and their work was just to buy and sell maize. And they were all putting this medication in, but they were never really wearing a mask year in, year out. Now they have a problem. Others were just using the sprays in the farms, okay? Flower farms, people just spray. You observe universal precaution, prevent yourself from inhaling anything that is harmful, and you'll keep yourself safe. If you are smoking, get help to quit. Because indeed, there are people who have smoked, apparently they don't have lung cancer.
They didn't get cancer.
They didn't get cancer. But that does not mean that smoking doesn't cause you to have it. That doesn't mean that then you smoke, you should not stop. We say if you're smoking, get help to stop, and you can be able to stop this. But otherwise, it is very, very difficult to pinpoint one item and say this is the real risk of lung cancer, none other. So we are all at risk. Okay. Yes.
I would like to talk about the various ways that you manage the condition once someone has been diagnosed, the treatment options available, how accessible they are. But first, I'm told we need to take a short break.
Indeed.
We'll come back, and then we tackle the issue of management, treatment, management of the condition. And also we look now into what you and your partners at Ampath and the rest, as well as the government, is doing to ensure that identification of potential patients, ensuring that they get the right medical assistance, and the rest of the issues regarding the project, so that everybody can understand that probably there is help somewhere.
Thank you.
And what they can do to access that help.
Exactly.
So, chitab kalenjin kibendi gimunye nga sarta, and then watch amun kitesta ingalali aga kanyoindet na miten studio. Mitanaga Lawrence Murunga ako inendet ko kanyoindet nebo hospitali nebo Mtrh netinyegei ak ngalek chebo seriat notok nebo bwonek anan lung cancer. Konoto matiloitu weksene matyan ketesta ngalalet en Oliep studio. Kainenyon ko Victor Korir.